about the medico-legal litigations in Bharat focused on perinatal asphyxia. Again, coming to the definition, the definitions are not uniform, but I'm not going to confuse you with that. WHO says that there is a failure to initiate and sustain breathing. Various bodies describe perinatal asphyxia is a condition where newborn experiences inadequate oxygenation before, during, and after birth, leading to potential organ damage, particularly to brain and kidneys. The key features are that there is impaired gas exchange, inadequate oxygenation and or removal of carbon dioxide, decreased pH in blood often reflected in umbilical cord gases less than 7, organ dysfunction, potential damage to organs such as brain, where it causes hypoxic ischemic encephalopathy. It can have effect on kidneys, heart, and others. The causes, as we all know, fetal distress during labor or delivery, placental insufficiency, inadequate placental function, umbilical cord complications, compression, and prolapse, maternal health issues like hypertension, diabetes, or respiratory disease. People are slow to act whenever there is a fetal distress. Our criteria are vague about the fetal distress. So all that kind of things need to be sorted out. As for the clinical presentations are concerned, they are characterized by low Apgar score. The score of 1 to 3 at 1 minute and 5 minutes are very important. Respiratory distress will be shown by grunting, flaring, and retracting. Cardiovascular instability in the child are in the form of hypotension and bradycardia. Neurological symptoms are many: seizures, lethargy, or coma. As for the management is concerned, we all know about the neonatal resuscitation guidelines, where the government is very serious about it, that any gynecologist or anybody who's delivering has to make sure that NRP certified person, whether the nurse or a doctor, is also available with you to resuscitate the child. You may not require resuscitation in 95% of people, but in 5% you may require resuscitation, where if you are trained, you can definitely take care of the child without leaving any mark. It is NRP guidelines are that as soon as the baby is born, dry the child, stimulate just by tickling in the soul of the babies, and in case if the child has still not been able to cry, then use for oxygenation, use bag and ventilation. This is just required in 3% of cases. Ensure adequate oxygenation and ventilation. Supportive care is required for monitoring and managing potential complications. These days, suction is avoided as a routine procedure. Having known asphyxia definition, start using Indian terms consistently, like NRP training, hypoxic ischemic encephalopathy. The stages are many. Again, I'm going to touch one of them. Apgar, we all know about it. Record umbilical cord or early gases if available. ABG करने में थोड़ी मुश्किल होती है, but I think whenever you find that the patient has a fetal distress, do collect the umbilical cord and get the gas analysis done. Resuscitation, if required, you must know that the trained person is available, what had been the duration and the neurological signs in the subsequent time. NRP steps, I again repeat, because we have done 3 training programs we have already done, and 2 will be done in the next 2 months. Here the preparations are required whenever you are conducting a delivery. Equipment should be ready, and you have to ensure personal trained is available. You must know about it that 80% of deliveries are done by nurses or the medical officers, and only in 20% of cases the gynecologist may be available. And for resuscitation, you can take it from me, in 85% the neonatal trained neonatologists are not available. So assessment of the newborn, you have to do it for tone, for breathing, and for heart rate. Key principles are that 5% need resuscitation. and 3 to 3.8% need respiratory support, which I just now talked about. Assess for intervention. Steps are made clear in NRP training. So my request is that anybody who's conducting deliveries must be trained and should be certified. Act timely and for effective treatment. The standard of care for knowing in the courts that it's the best care, the courts assess whether your conduct and the treatment met the ordinary competent professional. I'm trying to say ordinary competent professional, which is this of the standard protocol. This is the Bolam's or Jacob Matthews' big decisions. The court does not look for perfection. Document your clinical reasoning. In Kusum Sharma principle is if two accepted courses or path exist for treating anything, choose one is not negligence per se. Poor outcome again alone is not a proof. Recall why you chose that particular path. As for the fetal monitoring is concerned, WHO and the Government of India insist that for the low-risk cases, you should do intermittent fetal heart manual monitoring. As for the high-risk cases are concerned, the continuous and appropriate intrapartum fetal surveillance is must. And charting remains pivotal evidence in hypoxia and in hypoxic ischemic encephalopathy allegations. Note baseline, variability, deceleration, and action timings. Not only the doctor should know, all nurses also should be, who are working in the labor room, should be taught by the gynecologist. Now, decision to delivery interval. This is very, very important, DDI. When immediate LSCS is indicated, non-assuring fetal heart as a sentinel event, court scrutinizes decision to delivery interval and reasons for delay. Time stamp decisions. Whenever you're writing your notes, you have to write down time, and it is good practice that below your signatures, you put a stamp also, so things are clear. Who's the doctor? Anesthesia and the team mobilization also should be documented. Again, time and spent. OT occupancy and incision time is also need to be documented. Now, escalation trail in emergency. Note every call and escalation. At what time the consultant was informed, pediatricians were alerted at what time, OT was ready at what time. Absence of traceable escalation is frequently attacked, seen across Indian consumer cases. Preparation to receive baby should be in place or not, it was there. Trained or certified doctors or nurse was available or not. Pediatrician at birth or an RTT, resuscitation team. For high-risk labor or cesarean section, record explicit presence or absence and arrival of the newborn care team. I think this is a big struggle. The spinal anesthesia is given, you have draped the patient, and you are waiting for the pediatricians to attend on to the patient. There are clear guidelines of IAP and NNF, and the government guidelines are also there, and all emphasize readiness to receive the baby. Now, this is a newborn resuscitation documentation sheet. I think, in every file it should be available, where details are there for a date of birth, time, and birth weight. Assessment details are there of the tone, breathing, and the heart rate, and then what intervention has been done. Did you do the stimulation, yes or not? Suctioning, oxygen, what was the concentration, whether it was room temperature, because now you require only room temperature oxygen is sufficient. This ventilation part of it, whether it was given, what was the duration, chest compressions are needed in a very 0.5% of cases, whether it was needed or not, and finally the endotracheal intubation. Vital signs again need to be assessed: heart rate, oxygen saturation, and their blood glucose. Outcome in terms of APGAR at 1 minute and 5 minutes. APGAR less than 3 is severe, 4 to 6 is a moderate asphyxia denotes. Disposition, whether the child was admitted in NICU, well baby nursery, or complication if there was any, and involved the persons who are there in resuscitation. Again, I just now said that the score of Up to 3 at 1 minute or 5 minutes indicates significant distress, and the Apgar of 4 to 6 indicates moderate distress. Potential future neurological problems expected are cerebral palsy, which has a delay time, can be there of almost 2 years. Developmental delays, potential delays in cognitive, motor, or language development. Learning disabilities such as difficulties with attention, memory, or academic achievements. Behavioral issues such as attention deficit or HD or anxiety to be noted in such people. There are well-designed guidelines for the same for diagnosis, and in neurodevelopment disorders such as autism spectrum disorder also to be noted by the pediatricians. Important notes are that correlation is not causation. A low Apgar score does not necessarily mean a child will develop neurological problems, and this is a really big Pandora box where people cannot predict who's going to have problems, who's not going to have problems. Many factors influence outcomes. Genetics, environment, and access to medical care can all impact child development. Early intervention is the key. Identifying potential issues early and providing appropriate support can significantly improve outcomes, because every minute matters. We have to adhere to the neonatal resuscitation protocol, and if it is there, it is a very strong defense for yourself. Document the initial steps, positive pressure ventilation, what has been the start time, ventilation checks, whether the child require intubation or only CPAP or CPR milestones, and Apgar at 1, 5, and 10 minutes are important to keep a filled NRP sheet in the file. Therapeutic hypothermia is a very, very specific topic and is a new development in the treatment of perinatal asphyxia for eligible HIE cases as per neonatal NRF protocol of 2021. I'm not going to comment on it because I'm not the expert for it. This has to be documented properly at the fetal, the neonatal age of 6 hours, pH and base deficit, and encephalopathy grading also has to be done by the neonatologist. Counseling, consent, start and stop times, and ineligible reasons if not done. These are all taken in detail by the courts. Post-resuscitation care like recording the glucose, electrolytes, seizures if any, ventilation, oxygen targets, fluid anticonvulsant therapy rationally, and the court sees this as a continuum of care. As for the anti-seizure medications are concerned, don't give prophylactically after asphyxia. Document when you treat and why. They are very strict NNF protocols. As far as the labor induction is concerned, informed consent that counts is very, very important. Labor induction or augmentation with oxytocin, any instrumental delivery and cesarean section, the detailed counseling is important. Should have a high-risk counseling, explicit mentioning about the fetal distress, HIE is risk when appropriate. All these things need to be informed to the patient and patient party. You should keep a bilingual signed forms with clinicians' notes, what all has been done. As for the oxytocin prudence is concerned, record indication, dosing, titration, contractions, fetal heart response, and stop criteria for oxytocin drip. Misuse, overstimulation appears repeatedly in the litigation's narratives in the court. Best practices in oxytocin use is every patient should have individualized care, close monitoring is must, avoid excessive uterine stimulation, be prepared for interventions. Induction and augmentation documentation, your Bishop score, membranes were present or not, meconium, parity of the patient, vaginal delivery after the previous cesarean section status, continuous assessment, show a thoughtful plan for your case. Meconium note onset, consistency, fetal heart correlation, resuscitation adjustment and neonatal suction, airway steps. This timeline often anchors causation arguments. For minimizing birth asphyxia, timely intervention is must if signs of fetal distress or birth asphyxia occur. Fetal monitoring, I've just now told you, use continuous fetal monitoring in potential fetal distress and high-risk cases. Communicate effectively with healthcare team and the patient about oxytocin use and the potential risk. This is the classification of hypoxic ischemic encephalopathy. This is the Levine's classification. You grade it into mild, moderate, and severe, depending upon what had been the muscle tone. Muscle tone is minimum in mild, marked in hypotonia, and severe in a severe variety, and whether there have been seizures or not. So again, the pediatricians take care of this in detail. Prognosis, the lack of spontaneous respiratory effort within 20 to 30 minutes after birth is associated with almost uniform mortality. I repeat again. बच्चे ने अपना spontaneous respiratory effort 20 to 30 minutes तक नहीं किया तो आप मान के चलिए बच्चे का bad outcome होगा. Living severe hypoxic ischemic encephalopathy, abnormal neurological findings persisting beyond first 7 to 10 days of life again signifies the same. Whenever there's an oliguria during the first 36 hours predicts poor outcome. Now referral or transfer. If problem escalating transfer is needed, document the rationale. Stabilization of patient, communication with the parents and the party, with receiving center. The transport mode and the time out and the time in the other center. NNF again has got a clear guidelines of referral and transport. Neonatal resuscitation, again I repeat, you require NRP training. आपने हमने जो ट्रेनिंग कराई उसमें सर्टिफिकेट नहीं दिया तो उसको ट्रेनिंग नहीं कहेंगे. This is only sensitization. Neonatal forum does a course which they charge money. All nurses in the country who attend on to the labor room have certificate. It is 100% mandatory and they've done it. As far whenever you give option to the doctors and if money has to be paid, the doctors shy away, and that's why they do not have the requisite qualification for the same. Maintain logs of periodic NRP drills. आपने ट्रेनिंग करने के बाद भी आपको ड्रिल्स करना पड़ेगी और उसके लॉग बुक भी रखनी पड़ेगी आपको लेबर रूम में. Mock codes and the staff certification has to be there. These are excellent defensive exhibits for you in the court. Equipment readiness, check for radiant warmer, suction, bag mask, oxygen blender, pulse oximeter, and emergency drugs. उनकी dates देखनी है, and add pre-delivery checks to the record room. When I'm talking about radiant warmer section, अगर मैं किसी gynecologist को कहूँ कि आप इसको on कर दीजिए, they can't do it. APGAR and a proof of negligence. Court weigh APGAR with the broader clinical picture, ensure correlates gases on the cord blood. Whenever you have a patient of fetal distress, see to it, or meconium, please see to it that if cord blood is collected for gas analysis. Again, neurological assessment, resuscitation logs are captured and put up in the file. Causation cautions are hypoxic ischemic encephalopathy and cerebral palsy can be multifactorial. I had already highlighted this particular thing in the beginning. Keep antenatal risk summaries like growth retardation, pregnancy-induced hypertension, diabetes, maternal infections, anomalies in the child to contest as a sole cause of intrapartum negligence. Indian cerebral palsy cohort cite asphyxia as risk, but not the only cause. Clear neonatal handover also need to be recorded as structured delivery note, neonatal admission note with exact times, intervention ties the story together. Duty roster and logs, producible duty rosters, call registers, OT logs corroborate who was responsible when, and a missing roster weakens your defense. So all these small things, they look very small to you, but all these things are important and they have to be caught up and cannot be done retrospectively. Medical records integrity, courts take missing, tempered records very harshly. Thorough notes often decide cases. Store partograms, CTG strips, resuscitation sheets, and the consents safely. Expert opinion, anticipate need, keep your hospital perinatal audit minutes, which have been done in the past, and morbidity meetings, show a culture of quality in your department. Courts often ask why decisions are made. Communicate early, document compassionately. Honest time disclosure and a documented meeting with the family post-event frequently mitigates litigation, compensation, quantum also. तो आपको बहुत ही sympathetic होना पड़ेगा and with the family and the family members. Consumer forum is a reality. In obstetric cases, again I repeat, 50% of litigations in the medical fraternity are against gynecologists of negligence litigation in Bharat. But my experience both at the Delhi Medical Council and the National Medical Council says that about 2/3 end without compensation. But documentation quality and the consent are the two things which make all the difference. Public sector versus corporate expectations. Commissions often hold corporate hospitals to be with a higher expectation they have from corporate hospitals. Ensure protocols and audits are demonstrable. Keep guidelines handy in the court. Place IAP, NNF, NRP algorithm. I think in your medical legal bundle, show your steps, match them perfectly. As far as this details of neonatal resuscitation is concerned, the people who have been trained have been told each and every step and demonstrated very simple to do it. And but all you have to be aware of it, and you must do it in the drills forms repeatedly. This is the same thing. Peri-viability and rise. Indian jurisprudence increasingly pushes life-saving care for newborn infants, document viability counseling, resource limits, and best interest decisions for the couple. Regular drills save babies and cases. Periodic training demonstrably improves perinatal asphyxia outcomes. Attach drill schedules and certificates to qualify for in quality folders. I again repeat, attach drill schedules in your department and the certificate of NRP training. Quick printable evidence packed, keep in every high-risk file. Partograms hona chahiye, CTG, fetal heart thing with the timestamps. Structured टाइम स्टैम्प वाली बात समझ लीजिएगा, आपका आपने दस्तखत भी करना और स्टैम्प भी लगानी है. स्ट्रक्चर्ड इंट्रापार्टम डिसीजंस, DDI रैशनल, आपने डिसीजन से जब तक आपको लिया है उसका डिटेल में डिटेल्स होने चाहिए. NRP resuscitation team, cord early and its gases, Apgar at 1 minute, 5 minutes, and 10 minutes. Neonatal admission sheet and HIE staging are also very important. Again, there is no one classification, but all things have to be maintained in detail. Again, I repeat that the duty roster, OT logs, calls, escalation records, all these things are important. Signed consent, induction, augmentation, instrumentation, and for cesarean section. NRP guidelines printout should be placed always in the labor room, so at least people know that this is a common display in your labor room. So take-home messages are to avoid cerebral palsy lawsuits are detect and manage maternal infections, identify and manage risk factors, which I just now highlighted, IUGR, PIH, diabetes and other things, perform medically indicated cesarean section, respond to fetal distress. You must exactly know what WHO defines in 2020 and what action need to be taken. Treat severe jaundice in babies, monitor fetal heart rate very meticulously during labor, use delivery tools properly like forceps and vacuum extractor, document effectively, communicate effectively, stay up to date with guidelines. So thank you very much.